Great. And so the last case study that we would like to cover today is another one that we received an inquiry from a clinician. So the question here was really around the idea of, can ACT be used in cases of asymmetrical or unilateral hearing loss?
It's a really good question and one that I hear all the time. So really interested to hear your thoughts on this, Michael.
Yeah, so this clinician, this question really came about from a particular patient that they saw who we've named Scott, who had a quite sudden onset left-sided unilateral hearing loss. Just to give a bit of a background of who Scott is and why he needed this investigation performed, he's a 59-year-old gentleman who works as a doctor. So he is very, very active and he's communicating in lots of very challenging situations, but also a lot of his communications very, very critical that he is hearing well. So he attended audiology due to some difficulties that he was having at work predominantly.
Okay, and what did his audiometric exam show?
So the audiogram was performed, and at that point it showed, arguably it's a bilateral hearing loss, but it's very, very mild high frequency loss in the right side, accompanied by a fairly flat, moderate sensory neural hearing loss on the left side. Otherwise, the exam was pretty unremarkable. There were peaked tympanograms both sides, and otoscopy showed no major abnormalities.
Okay, so I can see there in the audiogram that masking had to be performed. So I guess this might be the reason behind the audiologist worrying about performing the ACT test. But what happened when we came to the ACT test?
Absolutely, and it's a common concern because the thought process there, as you pointed out, is really, well, if I have to mask for pure tone audiometry, why don't I mask for audible contrast threshold? And really, this comes down to two main facts, and that's that first of all, this is a binaural test, whereas in PTA we are very much trying to separate out the ears to get accurate unilateral thresholds. In ACT, we are simply looking at the overall abilities for that patient when they are hearing as they normally would. Second to that, where pure tone audiometry is a threshold test, ACT is a suprathreshold test. So we spoke about with Janet earlier that we present at a level of roughly 15 dB sensation level. However, another part of that is actually that the lowest level that we present the stimulus ACT is actually 62.5 dB. So even in the case of normal hearing, we still present quite a bit louder. And therefore, if we think about the typical intraoral attenuation of our transducers, so for circumaural headphones, that's about 40, for insets, about 55 usually, to actually get any meaningful crossing over of the ACT stimulus, we're going to have to be presenting into that bad ear in excess of 100 dB before it's going to cause any issues. So realistically speaking, for Scott in particular, with this level, we had a look. We programmed in his hearing loss. And we had a look at the levels that were set automatically for ACT, and the levels in his case were not going to cause any issues with crossover.
Yeah, I can see that being only at 50 dB. That's not going to have any levels or significance at all. So, what did his actual ACT score show then? So we can continue with ACT, but what did his results show?
So Scott's ACT score was initially quite interesting because he actually scored a perfect -4 on his
Very impressive.
which is very impressive until we look a little bit closer and we actually see that there are an awful lot of false positive responses in this ACT test. So what this pretty much tells us is that we suspect that Scott was perhaps just pressing the button quite a lot and therefore may have artificially inflated his abilities.
Okay, so just like in pure tone audiometry, in ACT, but with ACT you get a flag up which tells you when this is happening.
That's right, yeah. So because of this, because the amount of false positives were identified, a decision was made to then repeat the ACT test after re-instructing Scott about how the test needed to be performed. At this point, he was much better at only pressing when he heard the siren sound. So as a result, his ACT score did drop by a little bit, but it was actually still pretty good. So he scored -0.5, which is still well within normal, but it does show the impact that these kinds of false positives can have upon the result that you get, and therefore the importance for us as clinicians to monitor these quality indicators as well.
So just focusing on that false positive for a counter for a little bit of time. If somebody had an ACT score of 6 but had a super high false positive count, would you then accept that being 6, or would you want to repeat it?
It's a challenging one because obviously the difference in Scott's ACT score didn't make any clinical difference because he didn't really change a great deal. However, when we have an ACT score of 6 and high false positives, we don't know if that's accurate. And the difference between, say, 6 and 10 is much more significant than the difference of -4 to -0.5, for example. So I think whenever we get these very high false positive rates, it's very important that we are taking the time to repeat to check for consistency in the result. Now, if it was consistently with false positives very high, despite reinstruction, despite all efforts to improve the quality of the data, then at that point, we really just have to make a judgment call on whether we trust the data or maybe we look to other means to try and investigate speech and noise performance.
I fully agree. So what happened next with Scott?
So we followed up with this clinician, and they advised that after this appointment, Scott did decide to go ahead with the fitting of a unilateral hearing aid. And given the ACT scores and the modern technology that he was fitted with, that score was implemented automatically into the hearing aid. Now, in terms of what that does, given the very good ACT value gathered, it tends to leave the sound profile very, very natural, which for Scott was actually a very big priority for him. And it's something that he reported very early on, was that he wasn't keen on hearing aids because of a perception that they were going to make everything sound quite strange. So for him, this is a really good result. And actually from a day-to-day perspective, he's finding it very, very useful.
Excellent. And so really, this is a really nice case because we've learned two things. First of all, we can do ACT in asymmetrical losses, and the loss would have to be hugely asymmetrical, almost with normal hearing and a severe, profound hearing loss before we would be entering that danger territory. But also, secondly, that we need to keep an eye on those false positives, because if they're super high, that's going to tell us that the ACT value isn't quite so valuable.
Absolutely. And I think really there's a common theme across all three of the cases that we've looked at today, which is just that we need to be mindful of what exactly the ACT test is measuring and how it is measuring it. So when we ask these questions of, well, we have a slightly more complex picture here, should I do ACT? We need to think critically about the individual and what it is that we want to know to make that decision, and also to know how we utilize that information when we gather it.
Absolutely.